Thanks, guys, for watching this video. The lesson today that I chose for you is chronic pancreatitis. I get always asked by medical students about chronic pancreatitis and its management because we talk to them a lot about acute pancreatitis, but chronic pancreatitis is kind of an issue that's not well demonstrated to medical students. Unfortunately, these patients who get chronic pancreatitis are a very unfortunate group of people. They tend to be people who've got a lot of psychosocial issues, drug addictions, alcohol addiction, and they tend to have multiple other comorbidities, usually related to these issues. But it's a real problem, and we see it quite often to warrant further demonstration. Now we need to know the etiology and what changes happens in the pancreas to lead to chronic pancreatitis. By definition, the process of chronic pancreatitis is an irreversible damage to the pancreatic tissue that affect both the exocrine and the endocrine part of the pancreas as a result of activation of the pancreatic enzymes within the substance of the pancreas before they get excreted as a result of usually alcohol consumption, which will lead to fibrosis and calcification of the parenchyma of the pancreas, and that process turns out to be irreversible and causes a lot of problem in the long term. Now, these patients do get acute attacks of pancreatitis, but one of the theories of chronic pancreatitis is that it is chronic from the beginning, which is manifested in the form of just subclinical epigastric pain after alcohol consumption that settles down and does not require hospital admission. But every now and then, usually after a binge of alcohol, they get an acute on chronic attack of pancreatitis. And the acute on chronic is exactly similar to any other case of acute pancreatitis and will be managed on the same lines. And because of the recurrent attacks of acute or chronic pancreatitis, the cumulative effect of that is ongoing damage to the pancreatic tissue that will lead to the chronicity of the problem with its serious manifestations. One of the rare causes for chronic pancreatitis that we need to highlight is the number one, the hereditary pancreatitis, and number two is the autoimmune pancreatitis. Now, these are rare entities. The autoimmune pancreatitis is curable with the steroids. The hereditary pancreatitis is very problematic because these patients have inherited a faulty gene, usually in the trypsinogen cationic enzymes, that will lead to recurrent attacks of acute pancreatitis. Chronic pancreatitis eventually will ensue, and they are at a very high risk of having pancreatic cancer. Unfortunately, it's a rare cause for chronic pancreatitis, but there are families somewhere in the world who do have this particular issue. In terms of the clinical presentation of these patients, you find they usually had previous attacks. They are known to have chronic alcohol abuse. If there is none, you need to explore their family history. And the troubles that we face with them is the chronic pain, and that is the major trouble with the chronic pancreatitis, is the chronicity of the pain that tend to be on ongoing daily basis, where they use painkillers most of the time. Every now and then we see a patient get acute on chronic attack and present with acute thrombosis of the portal vein, and that the management of that is no different from portal vein thrombosis related to any other cause by 6 months course of anticoagulation. Some of them become diabetic as well, and they managed as a diabetic patient. But that's not very common complications. However, steatorrhea is very important to the extent they get malabsorption and also they get, in addition to the malabsorption, they get malnourished, and it will be difficult for them to put any weight on. How do we diagnose chronic pancreatitis for certainty? Usually it is with imaging, and the imaging of choice that we use is CT scan of the pancreas, which will show calcification in the pancreatic substance. Calcium carbonate precipitation occur, and that get involved and included within the protein plugs that occur in the minor ducts as a result of the pancreatitis, which will lead to permanent calcification. In addition to that, some patients will have dilated pancreatic ducts. That's not the rule. Some of them do, some of them don't. MRCP is extremely useful to show the anatomy of the duct. It will show us how the duct is dilated and the presence of certain strictures. Typically, the appearance is called a chaining of lakes, just like what we see here on this good quality MRCP scan for the pancreas and the biliary tree. So it looks like a chain of lakes because of strictures, multiple strictures, and areas of dilatation of the main pancreatic ducts. Certain patients might have disease affecting mainly the minor ducts, where the main pancreatic duct will not become dilated, and this tends to be less severe in its nature in general. Imaging will also help us to, particularly MRCP, to sometimes find cases of pancreas divism, and pancreas divism is embryologic abnormality of the pancreas, where there will be failure of the union of the dorsal duct of Santorini and the ventral duct of Vorsine to unite, which means that the duct of Santorini will drain the majority of the pancreatic tissue, including the body, neck, body, and tail. And as a result of stenosis of the minor pancreatic papilla, they could get chronic recurrent attacks of pancreatitis, and MRCP is very good to visualize that. This is again a rare cause. Pancreas divism is a rare cause for chronic pancreatitis, and it sometimes can be treated by endoscopy, by sphincterotomy. Now, if we get an acute attack, because this is a common problem, we will manage them non-different from any attack of acute pancreatitis. So they will come into the hospital, not by mouth. We watch their inflammatory markers, the CRP and their white cell count. We watch their clinical progress. They get pain control, accordingly intravenous fluid, and they eventually will subside, but they could get the complication that could arise from any acute pancreatitis, which is the necrosis of the pseudocyst and the rest of it. Now, if they have these complications, if they get pancreatic necrosis, then they might require pancreatic necrosectomy if they don't settle and their inflammatory markers does not settle down and they continue to have pain. We manage pseudocyst in a similar manner exactly, and if they need drainage, the drainage will be done preferably endoscopically and sometimes surgically, laparoscopically into the stomach. They have to be large pseudocysts, as you remember, and they have to be there for longer than 6 weeks and be symptomatic. Venous thrombosis, as I mentioned earlier, no different from venous thrombosis or for any reason. There are rare cases also of acute portal biliopathy as a result of portal vein thrombosis. And what does that mean? There is acute and there is a chronic form. The acute form is intrahepatic bile duct necrosis as a result of vein thrombosis. So it is an ischemic necrosis that can lead to cholangitis, and it can lead to biomas within the liver. And the management of that will be percutaneous drainage for large biomas plus antibiotics, and often they do settle down. Abscess formation. Abscess occurs as a result of infection of any necrotic material of the pancreas or infection of a pseudocyst, and the standard treatment is drainage. We prefer endoscopic or radiologic drainage in these cases. Now, there are chronic pancreatic patients where the chronic pancreatitis issue involves mainly the head of the pancreas, and that can lead to scarring and stricture of the duodenum, which will result in gastric outlet obstruction. Also, it can lead to bile duct scarring and obstructive jaundice. And these situations, very often, they don't respond to dilatation, and they will need surgical bypass management. And the bypass operation will be a gastroenterostomy or to the bile duct, where we do a hepatico-jejunostomy in patients who have obstructive jaundice. Now, this is again not a common operation, but it is known complication and known problem that will need to be addressed in a surgical manner. Now, we find one of the most important issues in the management of chronic pancreatitis is managing their pain. We do refer all these patients to the chronic pain clinic, and they get treated accordingly with opiates, non-steroidal anti-inflammatory drugs, and other medication. There are minimally interventional procedures that can be performed, and they have a certain degree of success. To about 60-70% of the patients will become pain-free or less dependent on opioid. And that can be done either a splanchnic nerve block or a celiac plexus block. This is done radiologically under interventional radiology by a pain specialist who will inject ablating material into the subsplanchnic plexus, which seems to be more effective than the celiac plexus, and it's done percutaneously through the back of the patient. Now, ERCP does have a role in managing chronic pancreatitis and the pain that's arising from it, particularly if the patient have got pancreas divisor, where with the ERCP we could do a minor papilla sphincterotomy. Occasionally, a main stricture in the main papilla, where the patient may benefit from usual sphincterotomy and insertion of a stent in the bile duct or the pancreatic duct if it is obstructed. So that's where the role of the endoscopy comes in for management of chronic pain and chronic pancreatitis. Now, steatorrhea tends to be a very common problem, and it's also a challenging issue to treat. The first thing we need to know is, in addition to the clinical history of diarrhea, they need to have a fecal test, and the most sensitive one is a fecal elastase test, or the quantity of the fat in the stools, alternatively to diagnose the patient with steatorrhea. Once they are diagnosed, we need to replace their pancreatic enzymes. We go to Creon, which is a lipase, and we start with a 25,000 international unit with each meal. With each snack, they will have another dose, and the patient could titrate and up the dose according to their response and according to the symptoms that they are having. Low-fat diet is quite essential to reduce the symptoms of steatorrhea. In addition to occasionally we use loperamide if it is so severe, and particularly when they have more than 4 or 5 bowel motions a day. Proton pump inhibitors are very useful, and we add them in the mix because Creon will not withstand the pH of the stomach. It means that it will be degraded and it will become inactive without having proton pump inhibitors. So with the proton pump inhibitors, we bring the pH to a higher level, which means that we can deliver the lipase safely into the small intestine to help in the process of digestion of the fat in the food. And the aim for these patients is to ensure they are nutritionally well and they maintain their weight. We often also involve a dietitian in this particular situation. Now, the role of surgery. Very occasionally, we need to do an operation for people with chronic pancreatitis, and the indications for surgery are very limited. And these are a drainage procedure or resection procedure. So there are two categories. The drainage is either endoscopic, which is, like we mentioned before, is sphincteroplasty or sphincterotomy. But the sphincteroplasty operation itself has gone out of favor since the addition of the ERCPs, and the possibility to do sphincterotomy via the ERCPs has totally abolished the sphincteroplasty that used to be done for patients with pancreas divisor. The other famous drainage procedure is the PES2 operation, which is basically a Roux-en-Y bypass for the pancreatic duct. So you see here in the picture the dark line where we make a long enterotomy, and also we open the pancreatic duct along the entire length of the duct part that is dilated. The longer the better. We can rectify the strictures when the duct is open. We also can remove calcifications and small calculi in the duct, and then we do a side-to-side anastomosis between the pancreatic duct and the Roux-en-Y loop of the jejunum. So this is the Roux brought up. So, and that will function as the pancreatic loop, and then here it will meet the small intestine where the food and the bile is coming from. And now the prerequisite for that is dilated duct that often is effective in controlling pain for patients with a chronic pancreatitis. Resection procedures for chronic pancreatitis are again possible, and that's done only if we think there is limited area of the pancreas that's affected, which can be in the form of a distal pancreatectomy. Rarely we need to do that. Or resection in the region of the head of the pancreas. Now, Whipple operation does have a role, but it's a very small role. Few patients might have a chronic pancreatitis and duct problem limited to the head of the pancreas, where they can limit from a Whipple operation. Less invasive than that is a modification of the PES2 drainage, where it's called coring of the head. So we try to core as much tissue of the head of the pancreas, which is thought to be the main source of the pain, and we leave the pancreatic duct and tissue open, and then we do a Roux-en-Y bypass. There is a more aggressive form of that, which is duodenal preserving pancreatic head resection. Again, these procedures are done only by a very specialized surgeon who's dealt with patients who suffer from chronic pancreatitis, and the indications are not that many. The results for the suitable patients is that it will be reducing the pain or making the patient opiate-free in about 70% of the cases. And those who need opiate to control the pain, they tend to need less dose, and they have less exacerbations of acute pancreatitis. So resection does have a role in that case of chronic pancreatitis. And as I mentioned in the past, biliary bypass is sometimes needed if the main papilla is strictured and we aren't able for technical reason to do an ERCP and sphincterotomy. A final note about these patients, as I said, these patients tend to be very unfortunate. They are alcohol addicts usually, and their addiction to alcohol could be associated with drug abuse, where they could get hepatitis C. Hence, they are a high risk for liver cirrhosis, and if they develop liver cirrhosis, that can become more advanced and complicate the issue, and they could die from hepatocellular carcinoma or eventually from liver failure. And that's all what I need you to know for about chronic pancreatitis and what the outstanding issues. I'm glad you have been with me today. I hope it has been a useful lesson, and I love to hear from you by interacting with us. I will see you in the next video.